Hello and welcome to our summer mentorship mini series. We're going to talk about interpretation of neurotransmitter testing, organic acids testing, how you can understand the brain, what's going on with the brain. So, I want to present a model, a clinical model of three different types of neurotransmitter problems, and then we're going to talk about how to fix them, basically. This is a high overview. This is probably not enough for you to actually be an expert, but this should introduce you at a pretty high level to what you need to learn and get you excited about doing this work if you're not doing it already. And if you're doing it already, hopefully, you know, we can up level your skill set. So I'm going to introduce myself. For those of you that are brand new, I am Dr. Dan Kalish. If you haven't done one of these before, we've been teaching online since 2006 at the Kalish Institute, trained thousands and thousands of practitioners. We've trained Mayo Clinic doctors. I've had my students placed in famous institutions like the Cleveland Clinic. We've worked with the best lab interpretation instructors, basically have trained me, including Dr. Bill Timmons, Dr. Richard Lord, and I'm passing on this previous generation's work with an updated, modern look to it, to the current generation of practitioners. And nothing is more important than our brains. I was thinking about this earlier today. Like, if we look back on I've been in practice like 33 years, whatever. You look back on these last 30 years of cases, and if I was going to really pick out the top 100 people where I felt like I really made a difference in their lives, it would all be brain cases. And so this is a skill set you really should put a lot of time and energy into mastering. I personally spent 12 years working every Wednesday for 12 years, every Wednesday, working with one of the top neurotransmitter people in the world. I followed him around. I taught with him at conferences. Um, I worked with him for 12 years to learn this work. So I'm not saying you can be an expert right away, but it's something that's very worthwhile to put your time into. And to that end, if you want to be an expert, sign up for our mentorship class, because at the end of the year of the mentorship program, you will be competent at interpreting these labs that I'm introducing you to today. So we have a new group that's starting in the next week. There's a couple of spaces left. You get a $1,200 discount basically if you scan that QR code. And if you're in that position where you really want to improve your lab interpretation and patient communication skills, or if you're just starting your practice and you don't know how to interpret organic acids and neurotransmitter markers yet, you should have a mentor. It doesn't have to be me, but if you don't sign up for my class, you better find somebody that's going to train you, because what's happening in our industry right now is practitioners are entering into practices without having any lab interpretation training, which is both infuriating and crazy making to me personally, because that's the whole point of functional medicine. Yeah, we do lifestyle. Of course, that's pretty straightforward, lifestyle coaching, but you have to be an absolute, savant at interpreting labs in order to get the job done. And so that's what, my training programs are all about. So if you guys want super successful practice outcomes, you want to really build your business around lab interpretation skills and patient communication skills and patient management skills, then the mentorship is the right class for you. And it's weeks, we meet weekly and we review in small groups your lab testing that you've done on yourself and your patients. And then there's a massive curriculum that you interact with that's all posted online. So it's our flagship product, and I hope a bunch of you sign up for it. Okay, so now let's talk about the biggest picture possible. Like, how do things go bad with neurotransmission in general? One, you can have a synthesis problem. You're just not making neurotransmitters for a whole variety of reasons we'll get into. Two, you could have the postsynaptic receptors where the signal is supposed to be going, they can be busted up and not working well. That happens a lot, especially when people have been using drugs, and it could be anything from cocaine to speed to an SSRI. Any of those can damage postsynaptic receptors or change the numbers of postsynaptic receptors. Obviously, it increases them if you're doing some of these drugs. And then when the drug is withdrawn, whether you're coming off the antidepressant or you're stopping, the use of the cocaine, then you've got all these receptors, but there's no neurotransmitters to fill them, so there's a problem. You can have neurotransmitter release issues. That's when we're stressed. You're stressed out of your mind. You're cranking out all these brain chemicals. And then you can have problems with inactivation of the neurotransmitters, okay? So there's a whole bunch of different ways that this can go bad, and you kind of have to figure out which of these problems is happening, because that's going to dictate how you're going to manage the case. Kind of obvious. So after 12 years of studying this every Wednesday and teaching this throughout the nation, I decided to come up with 3 types of imbalances, just so we can have a model and a structure. 3 types. Deficiency type, that means it's just not enough brain chemicals. I don't know, that's like your car running out of gas. Even worse than running out, I mean, if you run out of gas, I've run out of gas many times because my old Honda, when I was younger and broke, didn't have a fuel gauge that worked. So I've probably run out of gas like 6 or 8 times in my life at least, maybe more. It's a problem. But what's even worse than that is what happened to my son over last weekend is his car ran out of oil. Has that ever happened to any of you? That's catastrophic, right? The engine failed basically in his Subaru. So deficiency states can be bad, like running out of gas. Okay, the worst thing is you have to get somebody, go find a can of gas, or it can be like catastrophic, like the oil in your engine running out. Deficiency states are a big deal. Neuron damage is important too. That means that the level of neurotransmitters, the physical amount of the brain chemicals could be fine. Could be fine. There's not a deficiency state present, but the neurons aren't conducting the signal properly. The neurons aren't working right. That's a whole different level of problem. From inflammation, oxidative stress, insulin resistance, lots of things can damage neurons. And that means that even if your neurotransmitter levels are okay, the signals aren't going to get through because there's damage to the neurons. And then the third type would be genetic related problems, which happens to some people, unfortunately. They just don't make or process brain chemicals very well. And obviously, you'll see that running in families. You can figure that out with a genetic test. You can figure that out with, talking to them, doing a family history and whatnot. So deficiency states, you can burn through neurotransmitters just because you're stressed out of your mind and end up deficient. You can have a digestive problem, and so you're not absorbing amino acids very well. You have deficiency state there. You especially see this with H. pylori cases where they have an H. pylori infection, so the stomach isn't working right, which is where protein digestion starts. And so then they have low amino acids and they can't make enough neurotransmitters. I mean, that happens frequently. You could also have depletion from drugs. You can even have supplement-related depletion. If you take 5-HTP by itself, if you take 5-HTP by itself for too long, then you're going to deplete the opposite neurotransmitter, which would be dopamine, right? You're going to boost up serotonin so much that you deplete dopamine. If you take tyrosine for too long and you boost up dopamine, you're going to deplete its opposite, which is serotonin. So sometimes people do this with supplements, believe it or not. So 3 types, a deficiency, a damage type, and genetic type, and trying to figure out from the lab work and from the history what's going on here. So damage types are probably the ones that you need to focus on because the deficiency types are kind of obvious. You just run the labs and you can see they're low and it's like, how hard is that, right? But the damage type is a little more subtle because you're talking about the brain tissue, the brain cells not conducting signals properly. And what could cause that? Neurotoxins and physical trauma. So many of the toxins that we're exposed to these days are neurotoxins, which means they can get into the brain because they're fat soluble and they ricochet around in there and cause damage. It would be like if you went into like a pottery shop where they're selling beautiful pottery and you had like 10 bowling balls and you just start to throw the bowling balls around the room and all it's like everything's cracking up. I mean, that's what happens when a mercury molecule gets into your brain. It's like a bowling ball just tearing through a bunch of glasswork and pottery. Not a good situation. So the damaged neurons, I mean, damage is kind of a nice way of putting it. The brain cells can die. They can be killed by this, right? They're eliminated. They're taken off this earth. They're just gone. Damage, gone. You can also have damage from physical trauma. like you hit your head against a windshield in a car accident because you're going 70 miles an hour and then you got rear-ended by a truck or something like that. You can also have physical trauma from falling off a horse and hitting your head, getting hit in the head by a baseball bat, hitting a soccer ball with your head too many times. And then the sort of signature TBI, or traumatic brain injury, of our era, or maybe it's the past, the current generation, I would say, would be, traumatic brain injury in veterans coming back from the wars in the Middle East, because one of the characteristics of these wars was that there were a lot of roadside bombs, and so these vehicles that we sent over there got blown up a lot. And in the beginning of the war, they weren't very well protected, so people died. But later, as soon as we figured out this was going to happen on a regular basis, they started to put all kinds of metal plates and structures in our Humvees and our different vehicles, so that when the bombs underneath these vehicles went off, soldiers survived. They weren't damaged or killed by shrapnel or by the vehicle actually blowing up, but they had major head injury, major concussions. And that has happened to, I think the estimates are like, 300, 400,000 people in the United States now, maybe closer to 500,000, somewhere in that range, have a TBI from serving in the military. So it's a big problem. And those are all obviously young men and young women with, brain injury that we have to look after and take care of, for sure. You can have a genetic issue. There's a bunch of different genes that can cause this as well. Okay. So, and I forgot to explain the format for those of you that are new. So I'm gonna go through these slides kind of quickly just to lay out the model, and then I'm gonna pull up a couple of cases, a couple of labs. We're gonna review them and design programs, and you guys are welcome to ask questions. Type in your questions into the little typing in question box, and I'll cover questions at the end, okay? Okay, so type 1, deficiency type. Talked about that already. I think that's pretty obvious. Diet, depletion from drugs, etc. Now, the thing to also recognize, and this is a little subtle, but maybe not so subtle, is that if you're stressed enough for long enough, that's going to damage your brain. If you're stressed enough for long enough, that's going to damage your brain. And there's a neuroscientist who has the most entertaining and educational books and videos on this subject. His name is Robert Sapolsky. S-A-P-O-L-S-K-Y, Robert Sapolsky. He's a neuroscientist at Stanford. And if you just Google Robert Sapolsky depression videos or something on YouTube, they'll pop up an hour-long video, and he explains how stress damages the brain and causes things like depression. He's also got great books if you want to read about this subject, but it's a big one that's missed sometimes, okay? Chronic stress. So the things that we can do, in terms of treatment, obviously, if there's a dietary factor that's causing this, you can fix the diet and then improve neurotransmitter production just from having people eat the right amount of protein, and just from fixing their H. pylori and Giardia and whatever other gut problems they have. So we're assuming that you've done that, right? You've got the diet figured out, you've treated GI infections, you've got normalization of absorption and healthy food coming into the system, so you take that off the table. Then there's a series of critical nutrients, B6, 5-HTP, cysteine, vitamin C, B3, calcium, there's a whole bunch of them. The way to really deal with that issue is to give the person a multivitamin, a good quality multivitamin with some essential fatty acids or fish oils, and then look at the labs and fix all the things that you see on the lab. But you want to make sure you cover your bases with all the cofactors and random little nutrients that people need with a comprehensive multivitamin and some omega-3s. And then when we add to that base program the specific amino acids that show up based on the lab work. Now, tryptophan and tyrosine are the two biggies, tryptophan being the precursor to serotonin, tyrosine being the precursor to dopamine, epinephrine, and norepinephrine. And we want to make sure that we get those dialed in. So this question comes up all the time. If someone is on recreational drugs, like they're using heroin or speed or cocaine, or they're an alcoholic, then I would recommend not treating them until they've cleaned up and are off the cocaine, alcohol, or amphetamines, whatever it is. So you never want to treat someone when they're an addict and they're actively using, but as soon as they stop drinking, they're going to have massive dopamine depletions. And you can then help those people dramatically. So I had a 5-6 year period of my career where I got a lot of referrals from addiction counselors and worked with a lot of addicts who are in recovery. And it's one of my favorite groups to work with. They respond so well to these programs. But obviously, we're not going to do that if they're actively drinking too much alcohol. But if you do have alcoholics in your practice that are recovered and they're not drinking regularly anymore, then these programs can work great, extremely great. Similarly, it always comes up with, what if they're on an SSRI or some kind of anti-anxiety medication or some bipolar med or whatever? I would say save that for later. If you're new to this, I would not jump in and start to treat people with amino acids that are taking mental health related drugs like antidepressants, bipolar disorder, anxiety things. You can do that very successfully, but I just don't think it's like something you want to do in your first year or two. But you should know that you can help people get off these medications. You can help them taper off the medications. You can help the medications work more effectively. There's lots that you can do, but I would think of that as like an advanced thing that maybe do once you've been working on this in this area for 2 or 3 years. That could be something you do. Or if you take the mentorship class, you could do this right away, because we talk about that in mentorship all the time. But I would not recommend doing any of these programs with someone on an antidepressant drug unless you have someone you can talk to once a week and you're in a class like the mentorship. Just don't do it. Just wait till you sign up for my class. So let's look at pathways, because when we look at the labs, we want to come back and reference the pathways, and you need to memorize these over time. Tyrosine converts to L-DOPA and then dopamine and then noradrenaline and adrenaline, also known as norepinephrine and epinephrine. So tyrosine is a precursor to dopamine and norepi and epinephrine. That's very convenient because you can use that one amino acid to fix all those different things. All right. And then on the other side, tryptophan converts to 5-HTP, which then allows you to make serotonin. And what's not on here and should be is melatonin. Okay. So it also has a big impact on sleep. Now, when we get to testing, you can test for tryptophan levels on amino acids and tyrosine levels on amino acids. And if they're low, there's a deficiency, and you give the amino acids to get the person balanced out. Easy. Additionally, there's markers like homovanillinic acid, or HVA, and 5-HIAA, which are metabolites or breakdown products of dopamine and serotonin. And we measure those on organic acids. So you can see the input side of this with an amino acid test. You can see the output or the metabolite side of this with organic acids. And then you get a complete understanding of what the heck is going on with this person. Okay. Super amazing. This is all test-based. And there's one kind of important factoid that's hidden in here I should just mention, and this is something you have to know. So write this down somewhere, okay? There's this enzyme here, you see tryptophan hydroxylase. So tryptophan converts to 5-HTP, but if there's enough tryptophan in the system, there's a block right here. Okay, your body will stop taking the tryptophan and converting it to 5-HTP. Then what does it do with all that tryptophan? Does anybody know? What's the main role of tryptophan in the body? Somebody type it in. Come on, somebody. What's the main purpose of tryptophan in the human body? Who knows? Come on, nobody? All right. Well, you guys definitely have to take the mentorship then. Protein synthesis. That's what tryptophan is there for. It's there to, what proteins? All proteins in your body except for collagen have to have tryptophan in them. And of all the proteins that you need, of all the amino acids that you need to make all your proteins, tryptophan is the one that's in the smallest amount. It's just a little tiny bit of it in there. So if tryptophan levels are low, you're screwed and you can't make proteins. That's the main role of tryptophan. But back to our story here. If you take enough tryptophan supplementally, this enzyme goes, okay, enough already, enough. We're going to stop making serotonin from this. We're going to do other things with tryptophan. But you see 5-HTP, you see how it's past that enzyme? So there is no break on 5-HTP. 5-HTP converts to serotonin endlessly. The more 5-HTP you take, the more serotonin you're going to make. So that's important to know because you can use tryptophan or 5-HTP, but once you understand this enzyme shuts down things, it allows you to assess which of them you should use in different cases and whatnot. Okay. Similarly, over here, tyrosine converts to L-DOPA. There's another word for L-DOPA. In the supplement world, we call L-DOPA mucuna. Mucuna pruriens is a plant from which one can extract L-DOPA. I've never done it. I don't like have a lab in my garage or anything, but there are people out there who grab that mucuna plant and they take L-DOPA out of it and they sell it to us in the form of mucuna. Okay, so it's the same thing on this side. Tyrosine converts to dopamine, but there's an enzyme here, and if the dopamine levels get to a certain point, the enzyme goes no, 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 no more, and tyrosine will no longer convert to dopamine. L-DOPA, also known as mucuna, is past that enzyme. So if you give mucuna, there's an unlimited amount of dopamine that you can potentially make. These are very important because there's 4 products you need to learn how to use: tyrosine and mucuna, tryptophan, and 5-HTP. And now that you see how these enzymes work, you can kind of get a sense of, at least the background on the pathways so you can see how to use what. Oh, for those of you that joined us late, we are starting a new mentorship class in June. If you want to sign up, you can save $1,200. There's a couple of spots still open. Scan that QR code, talk to our team, and let's see if that's the right fit for you. It's an in-depth, year-long, what do you call it, like experience. It's actually kind of fun. I mean, I just talked to all the graduates from last June's class. People really like this class, and it changes their practices and it changes their lives consistently. I just did a whole bunch of exit interviews with the 1-year people that just graduated last week, and it really does, for real. I'm pretty proud of what we do here. And it's not because I'm an amazing person. It's because there's peer-to-peer learning. We have the best faculty in the world that are teaching along with me. We have great curriculum. I'm just presenting Richard Lord's work, Dr. Timmons' work. I've just put all of these amazing luminaries in our field into an online structure, okay? The main thing I've done is organize it, to be honest. And then I've learned how to teach this work because I've been doing it for almost 20 years. And the teaching is, like, how can we take a practitioner and get them up to speed on labs and patient management and get them the confidence they need in a year so they can go out there and just have the best practice for the rest of their career that you can imagine, and we're able to accomplish that. So those of you that are interested, check out the class. All right. Now, and by the way, just to acknowledge the whole, what is the main role of tryptophan? We have 3 people that got that question right. And all of them, I know their names well, are mentorship graduates, okay? So those of you that didn't know the main purpose of tryptophan, if you had taken the mentorship, you would have gotten that right. I mean, that's a pretty important thing to know. Like, a lot of these critical elements of knowledge just don't get transmitted if you're just doing one-off 1-hour webinars, or if you're calling the lab company and trying to interpret labs by calling the lab company. I mean, that's just a crazy way to try to learn how to run your practice. Nobody would do that in normal. Imagine if you walked into like your cardiologist's office and you're like, oh, okay, well, I know I had that, angina problem, and I know that my treadmill test wasn't so great, and I know you did all these labs. So, Dr. Smith, could you please tell me what was on the labs? And she's like, okay, wait a minute, just wait a minute. And she picks up the phone and calls Quest. And she's like, hey, you person who work at Quest, could you help me interpret this lab? I got a patient right here. And you would just think that the doctor was like nuts. It's like, isn't there a training program that you went to? Didn't you go to like, some residency? There's a lot of medical schools out there in the sense of functional medicine medical schools that are really great. My program, all my programs really, but the mentorship in particular is like the residency. That's where you learn how to do this stuff. That's what we're trying to do. All right. So now back to our regular thing here. Neurotoxin damage from either chemicals or heavy metals. You can also have physical trauma. Either of these are going to damage your neurons. So now this is really important because you can have normal serotonin levels And if there's enough trauma, the serotonin neurons aren't going to work very well. You could have normal dopamine levels on the lab work, and if there's a lot of neurotoxins that have damaged dopamine-related neurons, they're not going to work really well. So it's very confusing here. You can have a deficiency of neurotransmitters, or the neurons themselves can just not work that great. In either case, the treatments are the same. What you're actually recommending the person take is the same, but the mechanisms are different, and you kind of got to know which thing is happening, because the deficiency state people are easy. You bring the levels back up, they're better, you stop, and it's done. The anxiety's gone, the depression's gone, the ADD is gone. It's just gone. The people that have damage to their neurons, you get the levels up and you take the treatment away, and guess what happens? Unless their brain is repaired, they're going to have symptoms that start to come back. So you need to start to understand how that actually works. And again, as I mentioned, military, we have super high suicide rates from some of it, right, coming from the damage and obviously the emotional trauma as well, but the physical damage to the brain. You see this in football players and basketball players, not basketball, but football players, hockey players, even soccer players, where there's damage to the brain that's starting to be more recognized as being a problem. So we're going to talk for a moment about depression and inflammation, and then pretty soon we're going to skip over to the labs. So inflammation is a big part of all this, and again, we're going to look at lab markers. So I want to point out the lab markers on this test here. Down at the bottom here, you can see urinary quinolinate and kynurenate. Those markers, when they're high, indicate neuroinflammation. So inflammation creates sort of excess running of this pathway. There's our tryptophan, there's this IDO enzyme, kynurenate, that converts to quinolinate, and that is a neurotoxin that damages the brain. So when we're inflamed, we make this kynurenate pathway goes up, and that can cause problems with the brain. And in a normal situation, it's a mechanism that was, the design team knew what they were doing here. So for example, if you get a really bad viral infection and you're inflamed everywhere, you don't feel great, right? Your brain should be slowing down. And then you get better, and then the system resets. But we're worried about chronic inflammation when these markers are high for long periods of time. And then the person has like a persistent neuroinflammation. How could that happen? Well, if you have a neurotoxin in your body, that'll happen. It's not like you have mercury on Wednesdays and then the mercury is out of your body on Thursdays, or like you only have lead in your brain on Tuesday and Wednesday afternoons. I mean, if you have environmental toxins that are in the brain tissue, that inflammation is persistent. It's persistent. And then when these levels on the lab go up that we're about to look at, people are in trouble. And what do they have? Depression, anxiety, ADD, memory problems, all that stuff. So mercury toxicity, lead toxicity, arsenic, all of these chemicals and heavy metals are highly problematic. And the brain does not respond really great to a bunch of heavy metals and chemicals bouncing around, damaging brain cells. So again, you want to think about deficiency state, or is there damage? Deficiency or damage? And how can you start to tease this out? Well, if you see neuroinflammation, it's very likely that there's damage going on. If you see low tyrosine or low tryptophan, it's very likely that they're deficient. You see what I mean? So if there's the neuroinflammatory markers, ththese ones here, quinolinate and kynurenate, are high, it's very possible that neurons are being damaged. That's what inflammation does. It damages things. If it's long-term, right? Again, short-term inflammation, no problem. Long-term, big problem. And then the last category is genetically based. It's a whole other subject we're not going to get into too much. I just want to let you know that that's the third thing, okay? We just don't have time. Okay, deficiency type, damaged neurons, genetic factors. Now, the treatments are very similar, and when we're going to look at the labs, we're really trying to treat based on what the labs say is wrong. Organic acids, kynurenine pathway, you got to remember those. And then, of course, the brain needs to be protected. So you need adequate glutathione. You need to make sure the liver is working right so these neurotoxins are flushed out. So there's a bigger picture here. Getting the brain chemicals working is an important step, but then you also need to get the diet right, get the gut right, because as I mentioned earlier, you need these amino acids to be in your diet, you need to be eating them, and you need to be able to break them down and digest them. Similarly, if it's a neurotoxin related issue, you better clean up the liver and get all the neurotoxins out of the body. Otherwise, the brain damage is just going to continue. So there's a comprehensive view here. And in the mentorship class, we do 3 sets of labs: hormones, GI, microbiome, all the GI stuff, and then organic acids together on patients, right? So once you see the hormone component, the gut component, and then the organic acids, you have a very comprehensive view of neurotransmission. You can see liver detoxification issues. You can see oxidative stress. You can see insulin resistance. You can see how the hormones are responding. You can see if the gut's working right or not. And once you get that view of all 3 sets of labs, again, hormones, gut, and organic acids, then you can develop programs that are addressing the brain from each angle at the same time. And that takes about a year to teach people. Let's see, these are some basic nutrients that you need, but let's look at labs. I talked about a lot of these things already. Yeah, okay, so let's look at the pathways here, and then we're gonna look at labs. So we have plenty of time for that. So number 1, you make serotonin from 5-HTP, or from tryptophan and then from 5-HTP. And so here's the pathway that we wanna focus on. And I'm gonna circle the things that we test on the labs. So we test tryptophan, and remember the main role of tryptophan is protein synthesis. What proteins? All proteins. Does that include hemoglobin? Yeah. Does that include every antibody that you make? Yeah. Does that, and it includes every mitochondria, everything, protein synthesis. That's the main role of tryptophan. So if you see low tryptophan on an amino acid test, you should panic internally and not express that to the patient, but you should be like, wow, this person has got a problem with protein synthesis. Yikes. And then you look at their chart and you see how screwed up they are health-wise. You're like, oh, that makes sense. They have like 16 different problems. Okay, so separate from that main role, tryptophan converts to 5-HTP, which is how we make serotonin and melatonin. And for the purposes of this class, you can either use tryptophan or 5-HTP to resolve the serotonin issues. And we talked about the enzyme here, so you know that the difference between the two. You can use either. You could use both, but I don't think anyone ever does that. Usually people pick one of them. Here's our kynurenate and kynurenate pathway. So, and here's quinolinate down here. So when the body is inflamed, when there's inflammation from what? I don't know, from gut infections, from neurotoxins, when the body's inflamed, then this pathway feeds down. See, product of inflammation, see that at the bottom there? And what does that cause? Really bad stuff, like neurodegeneration. So you got, just think of this pool of tryptophan just in your system, used primarily for protein synthesis, but also to make serotonin and melatonin. Now the patient walks in and they say, my joints always hurt, I'm tired all the time, my sex drive is bad, I can't sleep, and I think I'm depressed. And I've been on, Prozac for 7 years, but it stopped working. Okay, you got to then figure out, is tryptophan going down here because of what? Because of inflammation. And that's what these lab markers are going to tell you. So if tryptophan is going down this way because the person is inflamed, clearly there's going to be a depletion of tryptophan going this way to help make serotonin and melatonin. And then we circle the markers. So we're testing quinolinic acid, kynurenate acid, that's probably this one here, sorry, kynurenate acid. We're testing tryptophan. We're testing the serotonin metabolite. In some of these labs, you can order melatonin testing. Oh, here's a metabolite down here. So we're measuring each aspect of this, and then you can tell what's going on. So let's just give a scenario. Tryptophan is low, 5-HIAA is low, quinolinic acid is high, and kynurenate acid is high. So then you're like, oh, the brain is inflamed. Tryptophan's going down this way, makes sense that they don't have enough serotonin. It's a dynamic picture you're seeing. Oh, and they can't sleep either. All from the lab markers. Okay, one more set of lab markers. Now we talked about tyrosine and how that works, right? But here's the actual pathway here. So tyrosine converts into dopamine, norepinephrine, and epinephrine. And if you're low, and phenylalanine converts into tyrosine, which is kind of convenient. So if you're low on the amino acid testing with phenylalanine or tyrosine, that means that there could be a problem making dopamine or norepinephrine or epinephrine. We can also test, so we're testing phenylalanine on amino acids, we're testing tyrosine. You might test thyroid hormones too. Obviously, we use tyrosine to make thyroid. And then you're measuring homovanillate and vanillomandelic acid, or they have two different names, right? Either homovanillinic acid or homovanillate, or vanillomandelate or vanillomandelic acid. They mean the same thing. So these are the urinary byproducts, right? The metabolites of the different catecholamines. And then we have these enzymes. This one's kind of famous, COMT, C-O-M-T. If that enzyme's screwed up because of a SNP, then you can have problems, right? So there's a genetic component to all this too. And that's a methylation-related enzyme. It's a methylation process that it runs. Okay, so sign up for the class, somebody. We want more mentorship students. In the meantime, let's give you guys a scenario here. So here's Diagnostic Solutions Organic Acids Profile, and we're just going to skip down to the section of interest because there's a lot on here. Isn't there? There's so much on here. Okay, here we go. So we just looked at this. So homovanillinic, that's the same as let me show you. Where'd it go? So some labs use the term homovanillate, some use homovanillinic acid. They're the same thing. Some labs might say vanillomandellate, and some labs will say vanillomandelic acid. They're the same thing. So here you can see vanillomandelic acid, that's the same thing as vanillomandellate, and homovanillinic acid, which is homovanillate. So this is high, homovanillate is high. That's the urinary metabolite for dopamine. So now right away, you know, just by looking at that, there's a dopamine problem. Then we scoot down here and we see, is there any neuroinflammation? Uh-oh, there's our kynurenate acid, sky high. That means there's neuroinflammation. Big problem. Here's our serotonin marker, 5-HIAA, also high. So now you're cranking through your serotonin, the brain is inflamed. We know that tryptophan's getting chewed up, used up in order to deal with the inflammatory situation that's going on. Not pretty, you know? And so then you're thinking, if you're a pathway person, you're thinking, okay, the kynurenate acid is high. I know there's neuroinflammation. Got that. Check that box. And then, let's go back to this diagram here. So this is high here, the kynurenate pathway, these markers, right, that's high. So you're thinking, oh, well, there's inflammation. So quinolinic acid or quinolinate must be high too. Should be. In this patient, it's not. It's even worse. Look at this. I don't know. She just happens to be on this lab. This is like an advanced idea, but you should know about this. So look, quinolinic is actually low. That's extra bad. If one of them is high and the other is low, that's even worse than them both being high. So anyways, this person's got a lot of neuroinflammation. Let's leave it at that. And then we look at oxidative damage. Oh, that's pretty high too. So when the brain experiences oxidative damage, it gets inflamed. Those things are related. And then what would you want to think about? Now, was neuroinflammation, well, where's it coming from? Well, glutathione doesn't look that great. That's the main protector of the brain, right? So you'd want to crank up their glutathione. Let me design a program with you guys here real quick. So this would be a standard program. So, and we're working on, let's just call it dopamine support. I've done this tens of thousands of times. It's way more effective than you could imagine. And it's worth you spending the time to learn. So we're going to use tyrosine. Usually comes in like a 500 milligram, 2 of them, breakfast, lunch, and dinner. You can do it on an empty stomach, but nobody ever remembers. So I would just, and again, I worked at this neurotransmitter company for 12 years. If you do tyrosine on an empty stomach, it's absorbed faster and there's more immediate results that the patient will experience. However, if you actually look carefully at dopamine levels, and I think in the data set we had back in the day was 3.4 million patient days of data. That was a lot of data, 3.4 million patient days of data. Tyrosine with food and without food, dopamine levels are identical. So it has a more immediate impact on an empty stomach, like you can feel it really fast, but the amount of dopamine that's in the body circulating over time is the same with or without food. So you can give it with or without food. If you want a fast effect, give it with food, without food, but it's easier for people to remember with food. And then we saw that there was a glutathione problem. So remember, glutathione is the master protector of the brain. So we want to use a glutathione, usually use liposomal, like 100 milligrams. And then we saw that the brain was inflamed. So now we got to like chase down, is there a toxin? What's happening with the gut? We don't have time to talk about that, but I'm just mentioning there's a whole nother, here, I'll just write it up here. Dopamine support start now. And then I would say 1, determine if brain inflammation coming from GI, so you're going to run a gut test, or toxin exposure. And then I would say also, just to be thorough, you can run a genetic profile, see if there's problems with the genes that are related to making neurotransmitters, and you could do a history for head trauma. So is GI inflammation, is it GI inflammation that's triggering this problem? Is it toxin exposure? There's a bunch of toxins in the system. Is it a genetic related issue? Is there a history of head trauma? You want to figure out this whole thing. But you don't need to figure it out in the short term. In the short term, you just want to get that inflammation down, and magnesium is the most famous way to do that. There's a special form of magnesium that is for the brain, so you can use magnesium threonate. It's really expensive, so you can also use magnesium glycinate, one of those. And you want like 100 to 200, no, that's not true. Let's say you want like 200 milligrams twice a day. So the threonate is especially for the brain, but it's super expensive. Regular old magnesium is pretty good too. Let me just write this better here. Let's just say you use a glycinate, 100 milligram pill. 2 of those there. And what does magnesium do? It helps calm down that neuroinflammation. Another great way to calm down neuroinflammation is with a curcumin type product. There's millions of them out there. That's very effective for brain inflammation. You can just like that. There's a bunch of other things you can do. I'll just give you one example here. Have the patient come back in maybe a week or 2, see what their response is like. If they're not responding yet, you can escalate and make the program stronger by adding in what we talked about earlier, that stuff called Mucuna. Mucuna, I would say, is an advanced product because it's a little dangerous because remember, it's past that enzyme. So you can screw people up with Mucuna. I wouldn't use Mucuna unless you're in a class like my mentorship or you have someone, down the hall that you can ask what to do. I wouldn't get into it because if things go bad on you, you're going to freak out and the patient's going to freak out. It's going to be a bad experience. But Mucuna, you need to learn how to use eventually. Okay. Just so you know, there's a stronger alternative here. That's an advanced product though. So there's your basic program. We're addressing the neuroinflammation. We're going to find out where it's coming from. We're going to flood their system with some tyrosine and some glutathione to protect everything. And then as I mentioned in the beginning, you're going to also use like a multi-pack of some kind, multi-pack with omega-3s. And of course, omega-3s are very good for the brain. And then you've got, in the multi, you've got all the little cofactors that you need. Okay, your calcium, your B6 and all that stuff. All right? Okay, so let's look at one more of these. And then type in your questions. We'll get to them in a minute. Now this is a NutriVal from Genova. And We're just going to scoot on down to the brain markers, which are right here. Again, this is a NutriVal from Genova. So it has, part of it is organic acids. And let's see, what do we got? Let me make this line up better. How's that? Okay. All right, here's another quiz question for you guys. What's the most important single nutrient in the reestablishment of serotonin levels? It's a trick question. When I worked at the neurotransmitter lab, we all thought it was one thing. Man, Lisa's nailing it. I'm telling you. Mentorship graduates got that right. Let's see if a non-mentorship graduate gets that question right. This is pretty damn important too. If you don't know this, you're in some serious trouble. What's the most important nutrient? And if you screw this up, it's not, the program's not going to work. I'm not saying this to make you guys feel bad about what you know or don't know, but you could give all the tryptophan and 5-HTP in the world, and if you don't dial in this one nutrient, it's not going to work. It's the rate limiting step in serotonin synthesis. And you're going to be like, oh, this Kalish guy told me to give him tryptophan and it didn't work. It didn't work at all. They got worse. That single most important nutrient, it's more important than the amino acids, is vitamin B6. We have one person that's a non-mentorship that got it right. All right. I wish I had gold stars or some bottle of champagne to hand out. Okay. It's B6. And how the heck do you know if they're low in B6? Well, there's a marker here, xanthurnic acid. It's a beautiful lab marker. I remember Richard teaching me about this years ago. So Richard Lord is my teacher. I worked with him for 15 years. He's still alive. He's just very retired, and he's in his 80s, and he's not exactly going to jump on a plane and fly to New York and do a conference anymore. But I talk to him pretty regularly still. So he loves this marker so much. He's the one that created the first organic acids tests back in the 80s. He loves this marker so much because it only means one thing. If it's high, it means that you're deficient in just one thing, and that's vitamin B6. And look how high this one is. The upper range is 0.9, and this person's at a 1.5. So this person's like literally off the charts. If they were going to graph this accurately, you see that? That's the high end of the reference range there. This dot should be like over here. It's literally, the high end of the reference range is 0.9. It's literally 50% higher than that, okay? So the higher that goes, the more deficient you are in B6. So you got to use B6. And when we were at the neurotransmitter lab years ago, we had this huge database that we're working with, right? Millions and millions of patient days of data. And you could see on the serotonin testing who was taking B6 and who wasn't. Because if you didn't have enough B6, you're just not going to be able to achieve normal serotonin levels. You have to have B6 in the program. Now, if B6 is deficient, you have a huge problem here. How much B6 do you need to give? At least 100 milligrams, at least, someone this deficient. And if you don't do that, the whole thing's going to not work. This is one of the reasons why people get frustrated with these kind of programs, because they don't know all the little detail-y in and out stuff. And it's very frustrating. I'm telling you, I've been in this position for a long time. You know, for my first 10 years of practice, I didn't know what I just taught you guys about B6. I never even heard that was that important. Kind of knew it was important, but I didn't take it seriously. I gave so many people 5-HTP and was always wondering, why isn't it working? It works sometimes. And be like, oh, maybe I'll try tryptophan. Maybe that'll work better, you know? And never knowing that it was a B6 deficiency. It's so frustrating. You're doing the right thing and you're missing one little part of it. So that's super, super important. This B6 marker will save you many, many times. And if you're nervous about it, which you should be, just give everybody a little bit of B6. Give them at least a B complex. And if they're a case that's really centered around brain issues, give them an extra 50 milligrams of B6. You know, that'll cover you, okay? So then this person's, unsurprisingly, their serotonin marker is also super high. To point out, that marker can go high if you're on an SSRI. So if you're taking an antidepressant, this marker is supposed to be high. But if you're not on a drug, it's not supposed to be high. Not on an antidepressant drug. Oh, and their neuroinflammatory markers high. So now we've got neuroinflammation, we've got B6 deficiency, and we've got this metabolite of serotonin that's just getting cranked out. And then the dopamine marker is borderline low. Okay, so that's going to try to keep all that in mind. And then, yeah, and so Francis asked an excellent question. I'm going to answer it now, even though I'm not supposed to answer questions yet. Yes, so zinc is super important, but remember that's in your multi-pack. That's why you're using the multi-pack, so you're covering all your bases. So now, just out of curiosity, what's the major way that you protect your brain with glutathione? So now on this particular test, they measure glutathione in the blood, and it's low. Not a good situation. That's like, I don't know. It would be like if you were in a situation, let's say you were in a battle situation. Oh yeah, like Vikings. Have you ever seen the show Vikings? It's a great show. One of my favorite shows of all time, Vikings. And they had like 6 seasons. It's a great show. The best part is when they invade France. And like, who would have thought? It's true. Like the Vikings actually sailed up the Seine River and they invaded France. Anyways, so in that Viking show, they always do this shield wall thing, you know? So like when the other like Viking tribe is shooting arrows at them, or like the French are trying to kill them all and they're shooting arrows and there's like thousands of arrows coming in, the Vikings, they're like onto this, right? So they're like shield wall. And then they all put up their shields like this. And they're very organized about it, right? And then all the arrows hit the shield, totally fine. And then they put their shields down, they laugh, and then they go kill all the French people. So glutathione is like shield. It's like shield wall to a Viking. Whoof, up there, no problem. You can shoot arrows at me all day. I don't care. I got this big old shield. I'm just here. It's the protector of the brain cells. So if glutathione levels are low, it would be like if the Vikings forgot to put their shields up, and now the French are shooting like thousands of arrows at them, okay? And they're like, oh, whoops, and then they just like bam, 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 right? So that's happening to your neurons. Your neurons are getting hit. They're being destroyed. They're being killed. Not just damaged, but killed. Like a human being would be killed if you had 16 arrows that went into your chest. That's happening to the neurons if your glutathione is low because your brain is unprotected. Okay, so this could be the origin of the whole problem, the low glutathione. Causing what? Neuroinflammation, because now all these neurotoxins are in the system, et cetera, et cetera. So if you, let's look at 1 or 2 more things, and then we're going to design a program here. So this test also includes plasma amino acids. And we don't have time to go through all of them, obviously, but I just want to highlight glycine is low. Let's just look at a few here. And tyrosine is not low. That's good, right? Tryptophan is not low. Okay, that's also good. So the amino acid side of this is okay. But let's go back. Now we're going to just do one more program design here. This would be a great program. And the fun part of this job is when people come back and they're better. Their memory is better and their ADD is gone and all their pain is gone. So now we're going to do, what did we say? I forgot already. Let's see. I have to go back and look at it. Hang on a second. We know I need glutathione. I just don't want to get it wrong. B6, glutathione, 5-HTP. Oh yeah, this is good. Okay, this is like different than the last one. All right. So we're going to give, this is going to be a serotonin reset program. We're going to use 5-HTP, say 100 milligrams. Somewhere between, let's assume that they have a sleep problem. Let's say anywhere from 1 to 3 before sleep. Then we had the B6 problem. So B6, that's usually sold as P5P. It'll say peroxyl 5-phosphate on the bottle. That's a fancy form of B6. Say we're going to give them 50 milligrams. They're super low in B6, right? So we're going to give that twice a day. Whenever you use B6 separately, you need to give B complex also. That's a general rule. You can never give a B vitamin by itself. So we got B complex. Glutathione was low. So this time let's use NAC for the glutathione. They sell it in a 900. And I don't know if you noticed, but I think I pointed out that the glycine was also low. So glycine is one of the amino acids you use to make glutathione. So that's pretty important. We want to make sure we get that back in. So NAC and glycine are two of the amino acids you need to make glutathione. So in this case, we're not going to use glutathione. We're going to use NAC and glycine because they've been shown in study after study after study to consistently boost glutathione. You don't have to use glutathione. This is a little way of mixing it up a little bit. Let's see. I think that covered. Oh, and then our multi-pack with omega-3s. Now, and of course, omega-3s are very important for the brain. And I think on this particular test, anyhow, the omega-3 index was messed up. We're not really talking about that too much today, but just so you can see here, where to go? Here, the omega-3 index is off, right? So we want to give them omega-3s, but we're going to give everybody omega-3s as part of the multi-pack experience there. So now what do we have in this program? We've got glycine and NAC to protect the brain. That's our shield wall, right? We've got the B6 because we just learned that's the most important nutrient. The most important nutrient in reestablishing serotonin levels is B6, otherwise it won't work. We've got the 5-HTP, which is the precursor to serotonin and melatonin. And then we've got our multi-pack, okay? All right, so now we're gonna go for questions. That was kind of a lot. Just a little review. 3 types of neurotransmitter imbalances. Learning how to use 5-HTP and tyrosine and how to protect the brain, and learning about neuroinflammation and where neuroinflammation comes from. If that's of interest to you, we happen to have a year-long program where you're going to become an expert at all of that. And you too then, a year from now, could be the one that's answering all these questions. You're like, I know that, I know that, I know that. All right. So questions. Number 1, yes. Is a nurse practitioner? Yeah, so there are a fair number of nurse practitioners that take the class for sure. So we have nurse practitioners, medical doctors, chiropractors, acupuncturists, naturopaths. It's a pretty wide range. We have a couple of osteopaths that are in the class right now. So yes, nurture, and we kind of, what do you call it? Open to people with all different degree backgrounds for sure. PAs too. Thank you, Lisa. PAs. As a matter of fact, there's a new PA, Lisa, that just signed up. I talked to him yesterday. Let's see. This lab we just looked at, which pattern was the patient? Oh, that's a good question. Well, their glutathione was low and their neuroinflammatory markers were high, so they had damage. Remember that neuroinflammation means neuron damage. It has to. Yeah, it's the tissues are being damaged. How do you decide between NAC and glycine or glutathione? I have a personal preference on this because Richard Lord taught me this. I always use NAC and glycine together or just NAC by itself to boost glutathione. I rarely use glutathione by itself because the reason for that is NAC does so many other things that it ends up covering a lot of bases. Now, if the patient's in really bad shape, you can even use both, but I much prefer to use NAC by itself or NAC with glycine, depending on how the labs show, because that'll boost glutathione, but it's going to do 10 other things that are really important at the same time. So B6 toxicity is absolutely a huge problem. Any nutrient can be a toxicant. You can take too much tyrosine easily. You can take too much B6 easily. So the way to avoid making these mistakes of using a nutrient to make your patient worse is to do the lab work. In this case, we saw the B6 marker was elevated, and then retest in 3 to 6 months. When that marker is normal, you take them off the B6 and you're done. So testing shows you what to do, and every supplement you recommend is only based on the labs. That's my motto. And then you retest in 3 to 6 months, you figure out what you can stop. If you do that, you will never induce a toxicity problem of any nutrient, I promise. Test, prescribe, retest. And you got to figure out the right dosages, obviously. For that, you can sign up for the mentorship. So good question here. When you have both deficiencies, dopamine and serotonin, you know what? I do them both at the same time. I would, yeah. So that's Lavina's question, I think. If you have a serotonin and dopamine problem, then you can give tyrosine 1,000 breakfast, lunch, and dinner, and tryptophan, 5-HTP 100 breakfast, lunch, and dinner. You can give them together. In general, you don't want to give 5-HTP by itself during the day because it makes people drowsy. But if you're using it with tyrosine, it works really well. So 1,000 tyrosine and 100 5-HTP breakfast, lunch, and dinner if both are low. And that, I've never had that cause drowsiness in patients, so you should be pretty good. Let's see. You guys are already thinking in the model. A bunch of people are asking what pattern was that? And then you can layer on top of this the genetic testing. That's a whole other thing, isn't it? But you don't have to do that in the beginning. So what brand of glutathione? I mean, honestly, I think the best brand right now, and most people would agree with this, for glutathione is Quicksilver. It tastes not that bad, which is an accomplishment, and they're just a great company. They have super high-end products. Maybe not cheap, but it's going to work really well. Many of the other brands of liposomal glutathione just are horrible tasting to the point where, you know, I bought some last year from another company. I won't mention the name, and I mean, I had to eat, just literally I had to take it out of the house because my wife was like, "That smells so bad," and I was like, "How do you smell?" It just, yeah, it can be very nasty. So Quicksilver, I think. Uh, Now, if the patient can't retest for some reason, then just have them stop after 3 to 6 months. Okay. If you're doing lab-guided nutrition, you see a lab marker, you prescribe for 3 to 6 months, and then stop, you will not create these problems. But if people, you know, have low B6 and they take B6 for 3 years, of course, they're eventually going to become toxic in it, right? That's inevitable. Okay, let's see. We're a little over time. I'm trying to answer the questions here. Let's see. So if the B6 markers are not off, there's going to be a little tiny bit of B6 in the multi. So you're going to get that covered in the multi. And a lot of the 5-HTP products that are sold also have some B6 in them. Which demographic finds the most success in your program? That's a good question. I think there's two groups. There's the medical doctors, PAs, nurse practitioners, DOs, that whole crowd. And then there's, and they usually incorporate what I teach into their existing medical practice. That's usually how that works. And then there's the chiropractors and acupuncturists and naturopaths, many of whom want to do full-time functional medicine and convert their practice over. Some of them want to combine it for a little while, but a lot of them end up wanting to do full-time functional medicine. And those are just two general groupings. And then there's people that are relatively new to the whole field of functional medicine that just need this basic training. And then there's other people who take the mentorship who are actually quite experienced. In fact, we had one of the presidents of one of the international naturopathic associations took the class like 5-6 years ago, and she took it because she just wanted a clinical model. That's what I'm teaching here. Like I just taught you guys a mini clinical model for the brain. I want to teach you a clinical model for everything in functional medicine. That's what the mentorship is. And so there's a lot of advanced practitioners who've been in practice for a while, and their practice has just gotten out of control, and they're doing so many different things, and they're overwhelmed. And the class can help them kind of bring it back to reality. But most of the people that we train, probably 80% of them, are within their first 3 to 5 years of practice, and they just need the boost. You know, they really need the boost. Let's see here. Taking melatonin does not raise serotonin. No. Oh, wow. Alice just signed up for the mentorship in real time while we're still here. Yes. So Alice, when you sign up for the mentorship class, I always want to do a one-on-one call with you before you get into the course. So in the next week or two, you'll get an email with a link to my schedule, and we'll talk about the course and how we're going to get your practice going in a great way. So glycine, to answer Lisa's question, is very calming. It's very sedating in a very good way. It's not like going to knock you out and make you tired, but it's calming from a brain perspective. That can work really well, okay? Let's see, Tammy's question here. Oh, we talked about B6 toxicity. I covered that already. Let's see, I think I got most of the questions answered. So 5-HIAA can elevate for a lot of different reasons. So it means that you're metabolizing or breaking down the serotonin at a rapid rate. There can be genetic reasons for that. There can be stress-related reasons for that. There can be medication-related reasons for that. So there's a whole variety of reasons for that. Okay, I'm going to wrap it up now. We're a little bit past time. Thank you guys so much. I hope to see some of you in the mentorship that starts next week, and have a great rest of your day. All right, bye now.